Good afternoon, everyone. I, Dr. Prajna Shettigar, on behalf of the Association of Ayurvedic Practitioners, Mumbai Kidney Foundation, Parul University, and National Sushruta Association, would like to welcome you all to the Global Integrated Certificate course in Nephrology. It is my great privilege and honor to welcome today's speaker, Dr. Shailesh Jaiswal, sir, our course director, Dr. Nilesh Doshi, sir, President Dr. Rajendra Ranawat, sir, Organizing Secretary Dr. Dilip Trivedi, sir, committee members of AAP, and all our delegates to another inspiring session. I would now request Dr. Nilesh Doshi, sir, to please carry forward the session.
Uh, Friends, today we were supposed to have two sessions. One is of Dr. Hemant Tosikhane sir, and another is of Dr. Manoranjan Sahu sir. But considering still the Sahu sir health is not permitting him uh, to speak such a long time, so I have taken it over on another topic. And next time, I suppose there will be, instead of two topics, there will be three sessions. Speakers would be there. So to fill the gap, I will take one session which is again very useful to the so many students and new practitioners who have not heard me on this subject in the past. So first, I will request Dr. Sailesh Jaiswal on behalf of Dr. Hemant Tosikhane, who is the Dean Parul University, has not been able to join because of certain unavoidable circumstances into the institute. He has to travel somewhere uh, uh, to Karnataka, and he's in traveling, so he cannot join at this point of time. So he has designated one of the senior most colleague and departmental person from the Salya department only. He is Dr. Sailesh Jaiswal, who is Associate Professor, Department of Salya Tantra, Faculty of Ayurveda, Parul University, Vadodara, Gujarat. He has done PG from Tilak Ayurveda College, Pune. So basically, he is from uh, Maharashtra. He has uh, he is pursuing PhD at Parul University, Vadodara, Gujarat. He has performed more than 10,000 anorectal surgeries, and he is practicing Uttar Basti in BPH in stricture urethra. Uh, so though he may be young, you might be seeing that he seems to be young, but he's having a very long and the number of cases point of view, he has got a very wide experience. It's my pleasure to present you Dr. Sailesh Jaiswal on prostatic abscess, prostatic malignancy, and urinary incontinence. Over to you, sir.
Thank you very much, Nilesh sir. Thank you very much. Without wasting too much time, I will directly go on to the presentation. Before that, I heartily thanks to the organizing committee who has given chance me to deliver my views, my opinion on these topics of prostatic malignancy, prostatic abscess, and urinary incontinence. So once again, I welcome you, all the viewers and all the members who have joined here. As Nilesh sir already introduced myself, and this topic I am going to present here, which is guided by my guide, Dr. Hemant Tosikhane sir, who is the Dean and Principal, Faculty of Ayurveda, Parul University, Vadodara, Gujarat. So, as you all know, the prostatic malignancy, it is the commonmost problem which is arising nowadays. Being a surgeon, we are going to incorporate plenty of carcinoma cases, but prostatic malignancy is amongst the one. So whatever the percentage of prostatic cancer in the India is there, top 10 will get the chance to the malignancy of prostate also. So before considering the prostatic malignancy, we just look at the anatomy of the prostate. So as you all know, the prostate is nothing but a walnut sized gland which is located in front of the rectum and below the bladder. Although the gland which is surround the urethra, which is a tube like channel, and that is responsible for the drainage of the urine and semen to the outside. There are some basic functions of the prostate is also there, because the prostate, which is the gland which is useful also, but due to some unavoidable reasons there will be a development of malignancy in the prostate. As considering the primary function of the prostate which secretes the prostatic fluid and which is having a very important characteristic that it gives nutrition, it protects, and it will give the liquidity to the semen, which help to transport the sperm from the other parts of the and to the exterior. So before going for the carcinoma of the prostate, we just look at some anatomical landmarks of the prostate. You can see here, this is the prostate which is seated on the base of the apex of the urinary bladder. There are two parts of the prostate is there. This is the base of the prostate and this is the apex of the prostate. This base of the prostate which is directed upward and which is near the inferior surface of the bladder, you can see here promptly. This is the base of the prostate, apex of the prostate, which is based on the inferior surface of the bladder, and this is the apex of the prostate which is directed downward and it's in a close contact with the superior fascia of the urogenital diaphragm. As you all know, the urogenital diaphragm which divide the two parts of the urethra, that is anterior and posterior urethra. So the base of the prostate which lies in close relation to the urogenital diaphragm, and these are the other parts of the urogenital tract. You can see this is the anus, as we have already discussed. The prostate is the gland which is superior to the anus, and this is the anal opening. You can see these are the seminal vesicles. This is the normal anatomy of the prostate. Now considering the blood supply, the inferior vesical artery, which is the branch of internal iliac artery which supplies to the prostate. Nerve supply, there are various neurovascular bundle, but most commonly we have to see the pelvic plexus of nerve which arising from S2 and S4 and also from T10 to T12. These are the nerve roots, and if any damage to this nerve root, which is also useful for the erectile function, if there is any damage to these nerve roots, there may be a chances of erectile dysfunctions are there. Before considering the malignancy of the prostate, the zonal anatomy must know to each and everyone, because there are 4 zones of the prostate, considering the peripheral zone, transitional zone, central zone, and anterior fibromuscular zone. You can see here, this is the anterior fibromuscular zone. This is the peripheral zone. This zone is also called as zone of cancer. In prostate, mostly the cancer, almost 75% of the cancers are found in the periphery zone or zone of periphery. Central zone and the transition zone, they are divide of the cancerous segment, but there may be some 5 to 10% of chances are there, can be a formation of the malignancy of the prostate. But the zone of the periphery is the most important zone where the cancerous tissue or the cells can be developed in the prostate. So transition zone 20% chances, peripheral zone 70% chances of cancer are there. Lymphatic drainage, there are different types of lymphatic drainage are there. Internal iliac group of lymph nodes, para-aortic, aortic, hypogastric, obturator, pelvic, sacral. These are all the lymphatic system which are connected towards the prostate. Now considering the metastatic lymph node, there are distant lymph nodes which are lie outside the confines of the true pelvis. The distance lymph node are nothing but the aortic, common iliac, inguinal, deep inguinal, superficial, supraclavicle, cervical, scalene, and retroperitoneal. This metastasis should know to each and everyone. Otherwise, what will happen? We will diagnose only the locally invaded malignancy of prostate. So what I am going to present here, that one should know each and every aspect of the carcinoma of the prostate. It is not like that holistically we can consider only the prostate and malignancies always stay there only. There may be a metastatic lymph nodes are there also there. Now considering the epidemiology, in Western countries, it is the second leading cause of the cancer death in men. Although it is one of the 10 leading cancer sites in male in India, but in Western countries there are huge number of cases have been found of prostatic cancer. Now considering the etiology of the carcinoma of prostate, family history, there are 2 to 3 fold increased risks in the men with a first degree relative having prostatic malignancy. There are some hereditary association are there, early onset of disease and Mendelian autosomal dominant inheritance according for the less than 10% of all cases, but it is 40% in younger men and in less than 55 years. So there may be some hereditary pattern which can be responsible for the transmission of the gene which are responsible for the production of the malignancy in the prostate. There are some racial factors are there, as the black and white population, they are having the incidence and mortality is striking rather than more in blacks. So these are some racial factors, that is black is more common rather than the white population. Some environmental factors also responsible for the development of malignancy of prostate. These are nothing but the Asian people which are migrating to the USA have a higher incidence of prostate cancer, as there is a environmental factors are there which are responsible for the development of the CA prostate. Diet is also one of the most important modifiable risk factor, as there is a high intake of fat containing diet. So fatty diet is predisposing factor for the development of the carcinoma of prostate, whereas the diet which is rich in carotenoid is nothing but lycopene. These are present in the tomato based products and vitamin E. These are somewhat protective for carcinoma of prostate. So if the person which is taking less fatty diet and is having a carotenoid substances, that is tomato based products and lycopene like vitamin E, these protect the prostate from cancerous elements. There is no any such evidences which can be found as a cigarette or smoking or alcohol use or height and weight and blood group which are responsible for the development of CA prostate. No data regarding the viral origin which is responsible for the carcinoma of prostate. No convincing evidences that the vasectomy which increases the risk of prostate cancer. Pathology: the 90% of the prostate cancers which are developing in the ascina of the prostatic ducts. These are adenocarcinoma, and rest that are incorporated in 5% of the cases. These are small cell carcinoma, mucinous carcinoma, endometrioid carcinoma, transitional cell carcinoma, squamous cell, basal cell carcinoma, and so on. So these are least common prostatic carcinoma that compromise only 5% of the patient. But most commonly occurring carcinoma is the adenocarcinoma, which is developing in the ascina of the prostatic ducts. Staging of prostate cancer, we have all know the normal staging of the cancer. TNM staging is there. So this is also one type of staging. So we can diagnose the patient, we can treat the patient according to the staging. Staging is very important. Staging is very important in the treatment point of view, in the prognosis point of view also. So we have seen there are different type of staging are there for the primary tumor, for the secondary metastasis, for regional lymph node enlargement. So we have discussed all these things. I am not going to deep in this because we have a lot much to discuss. and we have very less time. So I am not going into the deep into this, that is Tx, T0, T1. As you all know, this is the primary tumor, this is the regional lymph node metastasis, and this is the distant metastasis. And according to this, there may be a classification and grading can be done on the tumor. So that is the most important point we are moving toward, that is the diagnostic workup, which is very important. Diagnostic workup include, first is the clinical examination, then comes towards the investigation. It comes into two parts. One is the radiological investigation and second one comes as a laboratory investigation. Firstly, we will go towards the clinical examination, because when the patient comes to us, the first, he didn't have any report, we have to advise him the report. But first of all, we should have our clinical diagnosis or clinical examination should be there. For that, we are going to do in our OPD basis management, we are going to do the digital rectal examination. That is called as a DRE. So digital rectal examination is very important, which can identify the prostatic tissue, enlargement of the prostatic gland, irregular wall development, mucosal fixity, identification of the tissue towards the rectum, and how it encroaches towards the rectum, in what content, in what extent it encroaches towards the rectum. That all the things we can be incorporated by digital rectal examination, and we can assess that either it is a benign pathology or it is a malignant pathology. So first diagnostic workup, we should go with the digital rectal examination. Then we can move towards the radiological imaging. We can advise patient for the transrectal ultrasonography. Most of the surgeon advise the biopsy also through this transrectal ultrasound examination, so that there may be a conclusive evidence can be made. Sometimes the patient, sometimes the surgeon prefer to do a needle biopsy of the prostate also. Then chest radiograph. There are higher chances of metastatic disease. So always in the case of carcinoma of prostate, we should go for the chest radiograph, that is X-ray chest, to see the miliary shadows or there is a cannonball appearances which is suggestive of secondary metastasis. Then in aggressive cases, we can go for CT of the pelvis to see the distance nodal metastasis. Then radioisotope bone scan also is very important to see the metastasis. Then MRI, PET scan for the bone metastasis in high risk cases. So this is the diagnostic workup we can go. First we will see the clinical examination, then we will go for the radiographic imaging, and later we are going towards the laboratory investigation. In laboratory investigation, the most important part is the serum PSA. Sorry. Serum PSA, that is nothing but the prostate specific antigen. It is found that is in PET scan, both the PSA and PET scan can be done simultaneously, and which is the important tool to see the prognosis of the disease also. Because when we do, the PSA is elevated and in PET scan there is a distant metastasis are there. So both the things are very important. We will see the normal values and other things of the PSA. But the PSA is very important to see the patient is having or recovering from the disease, or patient is getting relief from the disease, that we can see by means of serum PSA. Diagnosis, the diagnosis is based on the digital rectal examination, radiological examination and serological examination, and finally a true cut biopsy, needle biopsy or truss guided biopsy is all can lead to the diagnosis of the disease. So serum PSA, usually the normal value is 0 to 4 Ng per ml. With increasing PSA level, there will be a chance of getting cancer increases, but is less likely to be the organ confined. Laboratory investigation, as I have already discussed with, in normal person it is 0 to 4. Mild elevation can be considered as 4 to 10 Ng per ml. Significant elevation more than 10 Ng per ml. The sensitivity and specificity of the PSA we can see specific is there. So it is not like that only the PSA abscess or prostatism, acute prostatitis. In these cases also there may be an increase in the PSA. So the specificity and sensitivity is comparatively less. So we have to go for the other investigation also. So carcinoma with normal PSA, there is only a 25% chances are there. But the carcinoma with the PSA level elevated, there may be a 75% chances is there. As I have already explained to you about the digital rectal examination, we have to give left lateral. There is a procedure of digital rectal examination is there. We have to give left lateral position to the patient. Then organ palpation should be done with the help of index finger. You can go craniocaudal and transverse dimension. So see the consistency of the prostate, mobility of the prostate, fixity of the prostate, mucosal involvement of the prostate. All the things you can incorporate it by means of digital rectal examination. So see, this is the index finger we have inserted through the anal region, and you can see this is the prostate gland. We can palpate only posterior and lateral gland, not the anterior gland. We are not able to palpate the anterior gland of the prostate. When we palpate according to the rectum through the rectal route, that is digital rectal examination, we can palpate the posterior gland and the lateral gland only, not the anterior gland. This schematic represented shows the digital rectal examination. You have to press here through the index finger. You can palpate. If the lateral lobe is enlarged, it is easily palpable to your finger as a rounded or oval or unequal shaped gland. X-ray, as I already mentioned you, chest X-ray, which can be shown pulmonary metastasis, some miliary pattern of the secondary metastasis can be shown, and UHG sometimes there due to the obstructive pathology of the carcinomatous prostate, the patient will develop hydroureteronephrosis. Some patient may have large post-voidal urine volume. Some may having retroperitoneal lymphadenopathy, and due to which some may develop liver metastasis. Some may develop soft organ metastasis. Some patient may develop there is a osteoblastic secondaries, that is the secondaries which can be developed in the bone, and patient will start at bone. So these are the higher risk group of patient of CA prostate which are having a very high risk group, and they are developed the skeletal metastasis. The role of CT scan in diagnosing the prostate gland as a size determination is very important, because when you do the CT scanning, the size determination of the gland is confined. In CT scan, there is a lymph nodal metastasis also got understandable, because most of the time in sonography, the most of the nodes are not going to be visible, but in CT scan, the lymph nodal characteristics are going to be understand, so that the surgeon can plan accordingly. Either he has go for adjuvant therapy or go for neoadjuvant therapy, and later he will go for the radiation therapy. So these things are very important before going for the treatment of the prostate. Then bone scan comes towards the bone scan. I have already discussed with you that higher risk group of people which are having a second osteoblastic secondaries, that is the tumor extended into the bone, they will develop the severe bone pain. And then in this patient, the clinical apparent metastatic disease, which is limited to bone in 80 to 85% of the patient of metastasis of CA prostate. So you can see this is a 73-year-old man's PET scan, you can see, which is recently diagnosed with the prostate cancer. You can see here it is the prostate gland which is recently, and these are the lymph nodal metastasis. You can see here, these are the liver, kidney, these are the salivary gland. In this patient, the PSA level is also elevated, and the PET CT shows the secondary metastasis in the bone is also there. Now, the most important part is the treatment. In modern science, there are different treatment strategies are available, and that treatments are depend upon the stage, PSA score and Gleason score, which is the aggregated score of the PSA, clinical symptoms, signs, some digital rectal examination. Accordingly, there may be a formation of one score that is called the Gleason score, and The treatment mainly depend upon the stage, patient age, general condition of the patient, early cancerous involvement, local advanced cancer, and some metastatic group of cancer. So according to these, the treatment can be offered, and there are three risk groups can be formed: low risk group, intermediate group, risk group, and high risk group, as according to the stage, that is the TNM classification, PSA scoring, and Gleason scoring. So according to this, there are three groups are there: low risk, intermediate risk, and high risk. And according to the treatment plan can be advocated. So if there is a locally invasive tumor is there, there may be observation. Sometimes the surgeon may prefer a radiologist, radiotherapy, radical radiotherapy. There may be an adjuvant, neoadjuvant, that is prostatectomy followed by radiation therapy. There may be a cryoablation. There may be a hormonal therapy. There may be a palliative radiotherapy as a symptomatic treatment, and hormonal therapy. So these are the treatment modalities which are available for the localized invaded tissue. These are the diagram for low, high risk, intermediate risk. So this is the surgical treatment of prostatic malignancy, that is the complete enucleation for the locally involved prostatic carcinoma. So this is the surgical treatment, that is a complete enucleation. You can see that is called as a prostatectomy. Nowadays there are different types of prostatectomy are there. Suprapubic approach is there, retropubic approach is there, and nowadays a laparoscopic approach and robot assisted approach are also involved as a evolution in the field of surgical management. So, but the young who have mentioned the radical prostatectomy, which is very popularized, and that is nothing but in this procedure there is a complete removal of the prostate can be done with surrounding capsule also removed, seminal vesicles, ampulla, and vas deferentia. So all the complete enucleation through to be done through the popular process of Young's operation. There are different approaches are there, that is Young's operation is also called as the suprapubic prostatectomy. Suprapubic. There are other approaches are there. Freyr's operations are there, that is retropubic transperineal approach. There are nowadays in evolution to the surgical field, there is a laparoscopic involvement are there. Some robot assisted procedures are there in which there will be a lesser blood loss. The magnification is very high so that the normal tissue and cancerous tissue can be identified properly. Three-dimensional visualization are there. Watertight anastomosis eases early removal of the catheter in that patient. So the life expectancy will be increased more than 10 years, and there will be no any life-threatening complication can be developed through the evolution in the surgical field through this approach. But the distant metastatic, that is distant lymph nodal metastasis cases in which the patient selection is very important, because definitely a male with a pelvic node and involvement of fare poorly, so controversy persists about the pelvic lymph node dissection, because we have already discussed that before going for the treatment we have to think about the certain stages like age of the patient, general condition of the patient, locally advanced tumor, metastatic tumor. So in pelvic node involvement there will be a low, if it is considerable to only the pelvic region, then the patient is having low risk. That is the lymph nodal dissection should be very promptly done. Otherwise, if there is any node which will be remain there, it will predispose to development of the cancer again. So extensive lymph nodal dissection should be done according to the patient condition, according to the stage, according to the degree of the malignancy. Now coming towards the radiotherapy, nowadays we have seen that surgery is not only the ultimate goal to treat the carcinoma of prostate, but the adjuvant therapies like radiotherapy, chemotherapy, hormonal therapy, these are very essential. So we are discussing here with the radiotherapy. There are three types of radiotherapy are there: adjuvant radiotherapy, radical radiotherapy, palliative radiotherapy. There are different radiotherapy are there. Means if the person is having grade 3rd, grade 4 degree of carcinoma of prostate, and he has done the prostatectomy, but later he needs to go for the radiation therapy. There are different techniques of radiation therapy are there, in which the conventional radiotherapy are there, which is very important. Conventional means you have to go for the, it is also called as a fractional radiotherapy. Fractional means you can see that people will go 5 days, will take the radiotherapy, then he will take a 2 days rest, then again from Monday he will start the radiotherapy. So in fraction you have to go for the radiation. So what is the importance of conventional radiotherapy? That the patient is able to, in that patient, the normal cells are able to get developed, they will get mature in that time. That is also called as a fractional radiotherapy. There are some other techniques like 3D CRT, which is also called as a conformal radiotherapy. Conformal, three-dimensional conformal radiotherapy. Three-dimensional, that is very important. This three-dimensional conformal radiotherapy can be done with the help of imaging techniques, so that the tumor which we have to give the radiation therapy, the remnant tumor which can be easily identified and proper radiation can be done. Some are IMRT and IGRT, which are nothing but the image guided radiotherapy and intense modulator radiotherapy are there, in which the intensity of the images will increase and the proper radiation should be given to the only the lymph nodal or the malignant area only get radiated. That is the important. And nowadays people are going for the proton therapy and brachytherapy. Proton therapy, proton is nothing but the positive particle, as you all know, and it is having less side effect on the normal cells. So people are and it is in this proton therapy there is no X-rays are there, only a proton rays are there, which are going to attack the cancerous cells. They will destroy the cancerous cell extensively. And last but not the least, that is called as a brachytherapy. And brachytherapy, as you all know, in which there is a radioactive material or radioactive seeds, which is called as, they are implanted in a certain area where there is a tumor is there, like in prostate is there, they will implant the radioactive seed or radioactive material, so that the radioactive material will target only the specific area. That is called as a brachytherapy. So these are the radiotherapies are there. Follow-up of the patient should be done 4 to 6 weeks after radiotherapy, then every 3 to 4 months, then every 6 months, then annually, and then 5 years once. So these all things should be follow-up, and in this follow-up you have to go with the PSA scan, PET scan and CT scan. All these examination you have to done at every follow-up. Complete history should be taken, physical examination and digital rectal examination should be done in the case of prostate, CA prostate. PSA should be done every 6 to 12 months, and imaging studies like PET scan, CT scan, whatever you have to go in each and every follow-up. Now comes towards the Ayurvedic approach to CA prostate. As you all know, in Ayurveda, Arbuda is a particular term. There are different terms are there for tumor like Gulma, Used, Granthi, Arbud. And Arbud is the particular term which can be used for the malignant tumor or the cancerous growth. So according to Ayurveda, the cancer disease process happen at a subtle cellular level. At the cellular level, each cell is a center of the awareness and which consists of macroscopic life. There is a flow of communication from one cell to another, and every cell has its cellular integrity and which governs its metabolic activity. And when there is a disturbance in this cellular integrity, then we can say that there will be a development of tumor. So according to the classical Ayurveda, the symptoms of the tumor we can say pain or painless, weakness, that is Dorbalya, malnutrition, that is Alpopochanam, extreme fatigue, that is Balashaya, as well as bone fracture. In case of extensive cases of CA prostate, we have seen there may be a fracture of bones can be happened, and even patient will develop a paralysis Paksha. These are the signs and symptoms of the Arbuda. These are the classical causes which can be mentioned in the Madhu Nidana and other text of where how the Arbuda can be formed. And these all the Nidan which are developed, which are mentioned by the Acharyas, are nothing but overexposure to the solar radiation, that is atapa sevan, excessive atapa sevan, overexposure to the solar radiation. Substances that have irritating property like drugs or alcohol, that is vidahi annapan. Penetrating cytotoxic drug like tishna aushadhi sevan. Toxic metabolic waste at the cellular level, that is cellular arm, that is called as cellular arm. Then incompatible food, viruddha ahar. Wrong lifestyle, viruddha vihar. Genetic predisposition, that is called as the bija dosh. We have considered in modern science that the hereditary factors are there. Parasite or microorganism in the blood, that is sushma krimi, which are also responsible for the nidan of the arbuda. Occupational hazard and exposure to the toxic substances, that is called as vyavasai. And psychological, emotional factors such as unresolved grief or stress, that is manovedana. All these factors which are contributing. Also age, in that people over the 65, they are more prone for the tumor formation. Samprapti, as you all know, the tridosh, masa, meda, which can deteriorate the rakta and they will develop the tumor. This is all about the samprapti. I am not going into the deep about the samprapti. Now, from Ayurvedic perspective of, we can say that prostate cancer is the tumor of the prostate gland, which involving the vitiation of all the three doshas, because the prostate gland forms a part of male reproductive system, that is Shukra Dhatu. So prostate cancer, which reflect the physical, emotional and spiritual relationship that affected man has had with his reproductive capacity. Because the Shukra Dhatu is the seventh and last Dhatu, and any disorder at this level also reflect the overall relationship with the entire body. So why Ayurveda has a role in this herbal treatment or cancer management? United States patent, they have already given a patent as a turmeric for healing. There are different projects are going on in the TKDL. We should have take wise step to conserve the knowledge. There are a lot of prescriptions are there. And for the solution, the complicated disorders and the standardization should be done according to the Ayurvedic medicines. So magical cure. Ayurveda is a magical. Some people say Ayurveda is a magical cure. No, it is not like that. Ayurveda is not a magical cure. Ayurveda is verbally a science of life, and in this science of life, there are some scope and limitation to the Ayurveda are there. So it is not a magical cure. It is a no magical cure, and there are some basic concepts are there in Ayurveda. According to this concept, there is a no magical cure. Only the diseases are classified according to the sadhyata, kricha sadhyata, yapyata, and asadhyata. I am not going to the deep in this sadhyata. And according to the patient can be managed by the basic Ayurvedic concept. So main things of Ayurveda management is swasthasya swastha rakshanam and aturasya vikar prashamam. The treatment are based on the principle which include first and most the surgical, that is enucleation of the tumor. Then go for the various procedure like snehana, svedana, vaman, virechan, nasya, basti, shar karma, rakta mokshan, and etc. Conservative treatment comes towards the shaman chikitsa, that is the herbo-mineral processed metals like zinc, copper, iron, etc. are widely used for the treatment of the malignant tumors. Phlebotomy, as all are practicing, that is nothing but a procedure which is used to remove blood from a person, and it is opposite of transfusion, which is a way give blood to a person. Phlebotomy is nothing but the rakta mokshan, which is we can practice in Ayurveda. Now discussing about the role of Ayurveda in cancer management as a prophylactic tool, as a palliative care, as a curative treatment, as a supportive treatment to improve the quality of life. Nowadays we can see in modern science also, after the surgical management, they have to go for the radiation therapy, they have to go for the chemotherapy, and there are a lot of complications are developed and there is a no solution at all. So what the role of Ayurveda in these cases? Surgical, it is okay. Surgery we have to do in extensive high grade tumor, but ultimately the quality of life of the patient should be improved. Some dietary advices are there. some palliative care are there, some symptomatic relief drugs are there in Ayurveda. We have to think about that, and we have to prepare, we have to standardize the treatment protocol for the management of cancer. So as an adjuvant or co-therapy, along with the chemotherapy or radiotherapy, we can use as a Ayurvedic role in the cancer management. So which is able to minimize the side effect of this therapy. So whatever the side effects are developed, that is nausea, vomiting, alopecia, redness, weakness, daurbalya, general debility, these are all the things which are developed after post surgery, post chemotherapy, post radiotherapy. These can be managed with the help of Ayurveda. In reducing the therapeutic dose of the various drugs, can be helpful in targeting the specific tissues, as in some studies, as nanoparticles of bolts are useful, which slower the progress of the cancer when chemotherapy or radiotherapy is giving in the patient where the surgery is contraindicated. In such patient, there is no other choice. They can be treated by means of Ayurveda. So they will improve the quality of life. They will also give the symptomatic relief and also add years to the life. There are some cytotoxic drugs are there, herbal drug, herbomineral compounds are there, which are found to be effective in some studies. There are a lot of studies. We will see the research activity, whatever done, or the anti-tumor action with the help of herbal and herbomineral drug. And there are some cell protective activity of the drugs which are mentioned in our classic, that is Rasayan therapy, which improve the comfort and the quality of life. So these measures we have to assess in the patient of carcinoma of prostate. The key factor, the drug regimen according to the body type of the patient, drug regimen according to the doshic environment, drug as a whole or its extract like water soluble, fried, dried, alcohol extract, soluble extract, and the chronicity of the disease should be checked. As an adjuvant or co-therapy, we can give this Ayurvedic management as a chemotherapy. Or nowadays, you can see the people are taking the snehana before going for the radiation therapy. They are taking lot much snehan. They are doing snehana. So you can advise the patient. You can continue the patient as a radiotherapy or chemotherapy. We don't have any issues. But you ask the patient to take the snehana because the patients are getting very tired, very weakened after this procedure. So ask the patient to take snehan. Use of antioxidant during the chemotherapy enhances the therapy by reducing the generation of oxidative stress induced aldehydes. So you give such drugs, the lot of components are available in Ayurveda text which having antioxidant production capacity, and give the antioxidant product before going for the chemotherapy and radiation therapy. Rasayan Chikitsa, Rasayan does not mean as a chemical. It is a therapy which enriches the Rasa Dhatu with the nutrients to help to one attain the longevity, memory, intelligence, health, youthfulness, excellence of luster, master or phonetics, that is Vaka Shuddhi, respectability and brilliancy which can be attained with the help of Rasayan therapy. It is not a chemical, it is the Rasa Dhatu which incorporated nutrients which can help to improve the quality of life. So we can add to this. As an adjuvant of chemotherapy, we can give Rasayan herbs. There are different formulas are there. There are prepared drugs are there. Some Rasayana which are having non-toxic herbs or formulas which balance the body in generalized way. And there are plenty of research has been undergone. Interestingly, I have already discussed with you, that is the Snehan Karma, that is intake of various medicated oil or intake of various medicated ghee or oil preparation in a classical way. A week or 10 days prior to the chemotherapy or radiotherapy have also shown a less toxic effect during the RT and CT. That is very important things which is going to see that before going for the CT and RT, you have to go with the Snehan Karma. There are many conditions when chemotherapy, radiotherapy or surgery are contraindicated in this patient. For in this patient, according to the age, according to the body resistance, you can go with the other adjuvant Ayurvedic therapy. These are the various anti-tumor plants are there. The various researches are going on in different CRI, CDRI, CCNSC, and all these things. In USA also, the Cancer Chemotherapy National Service Center, they have incorporated the extract of thousands of plants as a tumor system consisting of for solid tumors and leukemias. Drugs and herbs can be used in the treatment of cancer. There are plenty of drugs which is having alkaloids, steroids, flavonoids, terpenoids, and they are very much useful in bioactive and Ayurveda preparation. Three major constituents are very important to maintain the health of the individual. That is Ahar, Aushadh, Vihar, which is also mentioned in our Ayurveda. Bala, that is immunity, which is also very important, which can be improved by means of Ayurvedic management. The target of the treatment is nothing but the control of cell division, promoting apoptosis. Apoptosis is nothing but the generation of similar cell, not undifferentiated cell. Promoting the cells at apoptosis, improving the tissue immunity, fortifying defense of the probable target tissue of metastasis, and preventing the recurrence. That is the target of the treatment of Ayurveda. These are the basic treatment which we are following. That is Shaman Chikitsa and Shodhan Chikitsa. That is nothing but the medicine which balances the vitiated dosha. Because our treatment mainly goes on dosha and dhatu. Panchakarma, that is Vaman Virechan Basti Nasya Rakta Mokshan, and the medicine that dislodge and expel the vitiated dosha from the body. So dosh and dhatu specific treatment is our mainstay. Healthy item which can produce the free radical and which will give the antioxidant. This is the cycle which is going on. There are plenty of drugs which are used for the different types of cancer which are mentioned in the CCRS website also. Brain cancer, oropharyngeal cancer, there are the different types of drugs. I'm not going to deep in these drugs.
Sir, sorry to disturb you. 10 more minutes, sir.
Okay, sir.
Yeah,
almost. There are plenty of drugs which are here in Ayurveda for the symptomatic relief are there. All Google preparation, as you all know, which is useful for the pain relief. So in metastatic patient for pain, we can go some nausea and vomiting. There are different list of drugs are there, but we have to implement it in the patients of CA, cancer, prostate. As an adjuvant or co-therapy, we can give a rasayan therapy also. There are different rasayana are there, triple R rasayan, Chawanprash, Amalki rasayan, Amrit rasayan. So all these things, the conclusion is that we have to add years to life and to add life to years. Give a quality of life to the patient, improve the quality of life, improve the lifespan of that individual by means of Ayurveda. So key to success is prognosis proper. Antaratma pravishyasi, that is called as assurance. Give hope to the patient, avoid multi-drug therapy, and stick to basics of the Ayurveda. So prostate abscess. Now our second topic is prostate abscess. I will finish within 5 minutes. I am taking only the important aspects. So as you know, all know prostatic abscess is nothing but an immunocompromised disease which is most commonly included in the diabetic and HIV patient, and which is formed by a microorganism. They will form small abscesses and they will coagulate to form a large abscess cavity that is called as a prostatic abscess. As considering the etiopathogenesis, previously the Nigeria gonococci, which is the most attributing factor which is responsible for the prostatic abscess, but nowadays one MRSA, that is methicillin resistant Staphylococcus aureus, which is also a causative agent, can be found in the prostatic abscess. Etiopathogenesis, as we consider direct inoculation or transrectal prostate biopsy, or during indwelling catheterization, direct spread, indirect spread, all these factors will be contributing for the production of prostatic abscess. Instrumentation, sometimes patient with chronic renal failure, hemodialysis, or diabetic patient and the HIV patient, these are immunocompromised patient, they will also lead to the prostatic abscess. In prostatic abscess, we can see the clinical features like purulent urethral discharge, which will be noted. Hematuria may be present, patient having perineal heaviness, rectal irritation, pain on defecation, swelling on the gland, And but when we start the rectal examination, that is the digital rectal, we can see there is a fluctuation is there, hot and tender spot can be seen on the surface of the prostate, and which is the very important sign of the prostatic abscess. As mentioned, rectal examination, fluctuation and tender spot. So diagnosis is based mainly on the clinical examination and some investigation. Now comes toward the treatment. In modern sciences, there is two-way options. One is the medical management and the other is the surgical treatment. In medical management, we can go with the broad spectrum antibiotic for 10 to 14 days. And generally, we can give as a seed bath of various Ayurvedic drugs like Panchavalkal Kashaya. And we can hasten the process by means of we can do the integrated approach by means of we are continuing the antibiotic therapy, we are giving some Ayurvedic painkiller drugs, some Google preparation, some seed bath with the help of Panchavalkal Kashaya, and we can manage these cases. Then surgical treatment, that is called as a transurethral deroofing is there, which will allow the drainage of the abscess cavity and early recovery of the patient. Transurethral drainage has been replaced by the less invasive percutaneous drainage. Most of the time when you do the transurethral drainage, there may be a large wound which is formed, but nowadays there is a percutaneous drainage has been done for the drainage of prostatic abscess. Ultrasound guided aspiration has also been done. This is the open drainage. Now considering the Ayurveda, according to the Sushruta Samhita, prostatic abscess can be correlated as a Abhyantar Vidradi. We can see that the Vidradi in Apakwa Avastha and Pakwa Avastha. So Sushruta has mentioned the two Kwatha are there and which we are implemented for our patient which is having liver abscess or prostatic abscess or Vangshanastha Vidradi, that is we can call it as a prostatic abscess, Vangshanastha Vidradi. So according to that, Apakwa Antar Vidradi, that is internal abscess without the pus collection, we can treat it with the help of Varunadi Gana Anupan as an Anupan of Ushakadigan. Sushruta Samhita, they have mentioned all these things, and we have to give Astapana and Anuvasan Basti should be given for the patient. Dietary regimen should be according to the doshik involvement, and bar be used internally. You have to go with the all medicine which are having Google preparation for the diminution of the pain. Urinary incontinence. Sir, some time is left or it is all? Nilesh sir, can I continue for 5 minutes? Hello?
Sure. Yeah,
yes.
You can take 5 minutes. 5 minutes.
Thank you, sir. Thank you very much. So considering our third topic is the urinary incontinence. Urinary incontinence, as you all know, inability to control the passage of urine. There are different causes are there. Most of the time, there may be an involuntary loss of the bladder control. And sometimes the patient may be having general bladder weakness. So these two things you have to keep in mind in case of urinary incontinence, because patient will come to you, he will say there is a leakage of urine. When he sneezes, he coughs, there may be a leakage of urine. That means there is an involuntary loss of bladder control. Sometimes the patient having general bladder weakness are there. So these things have to be correlated and these things have to be ruled out. So there are different types of incontinences are there. Now we are discussing the causes and risk factor. Bed rest after major surgery or patient recovering from the surgery. There is a too much time patient is having bedridden tendency. So they are failed to control the sphincter and there is a involuntary loss of the movement of the sphincter and patient having leaking of the urine. There may be some loss of bladder sensation is there. Alcohol also, that is postponement of the urination during the alcoholism. Most of the people are taking alcohol and they are sitting there only. They are not going for the urination and they are also develop this kind of problem. Overreacting bladder is there. Mental confusions are there. Pregnancy, that is the weight of the child or the prostate will causes leaking of the urine. Prostate infection are there. Stool impaction, that is constipation. The loaded rectum will impose the pressure over the bladder and which trickles the urine as a leak. There are different causes are urinary tract infection, polyuria, caffeine induced, some drugs induced, Alzheimer disease, Parkinson disease, and stroke and spinal cord injury, in which there is a destruction in the bladder weakness. There will the bladder weakness which is caused in the Alzheimer's disease and Parkinson disease also. There are various type of incontinence are there: stress incontinence, urge incontinence, overflow incontinence, functional incontinence, gross total incontinence are there. Stress incontinence, we can see that in childbearing age, or the ladies or women who are having a menopause or pregnancy, they are having a cause of stress incontinence. The stress incontinence mainly occurs when the sphincter muscle of the bladder is weak. In males, after the prostatectomy, the person can lead to the stress incontinence. Urge incontinence, you can see it occurs in patients who have strong, uncontrollable, involuntary urge to urinate, and which leads to uncontrollable void if urine. Means if the patient is having full bladder and he is waiting for this, and that will cause the urge incontinence. Mostly in Parkinson disease, Alzheimer disease, or stroke injury, or nervous system damage. In these cases, we can see the urge incontinence. Overflow incontinence, it is a constant dribbling urine usually associated with the urination. Overflow incontinence is occurring after urination. Means the patient is retaining the urine for plenty of time. There may be some tricking of the urine or leakage which can be occur. Functional incontinence. The most important example of functional incontinence is in patient of severe arthritis which is not able to unbutton his pants quickly enough. That is called as a functional. Means the functional immobility is there, functional disaster is there. So person of rheumatoid arthritis is not able to open his button, and so that he has a leak flow of the urine. That is functional incontinence. Gross total incontinence, it is the cause may be injury to the spinal cord, urinary system, or by abnormal opening. The cause of the gross total incontinence is nothing but the formation of the vesico-vaginal fistula. There may be a tract formation that will approach from bladder to exterior to other sides. These are the clinical features which we can see. Investigation, we have to go for the complete urine analysis, residual urine measurement. Then urodynamic studies we have to done. Urodynamic studies, we can assess the flow rate, we can assess the maximum flow rate per second, and according to we can increase the flow rate. These are the radiological investigation. Differential diagnosis are there. Medication in modern science, behavioral technique, drug therapy, medical devices, interventional therapies are there. I am not going into the deep surgical management. According to the Ayurvedic management, we can consider this urinary incontinence as a mutraghat. There are different types of mutraghat as Acharya mentioned. But the most important treatment we are giving for the urinary problems, that is the Uttar Basti. Kashaya kalpa sarpishi bhakshan lihan payansicha shara madhyadvasa svedvan basticha uttar satnitan vidyan matimat tatra vidicha shvarinasham. So we are using the drugs in the form of Kashaya, Kalpa, Sarpi, Bhaksha, Uleha, Paya, Shara, Madhya, Asav, Svedan, Basti, and Uttar Basti. And these are all the formulation which is told by the Acharya Sushruta in the context of Ashmari and Mutrava Stotas. These are useful in all these conditions. So thank you all. Thank you, sir.
Thank you, sir, for a marathon session.
Thank you, sir. Thank you.
Yeah, and I know that we're running little short of time.
Yes, sir. Yes, sir.
In last two sessions, but still, as I have told you, it's 50 minutes, but still we gave you more than 65 minutes.
Thank you, sir. Thank you very much. Thank you.
Yeah. Because we know that you have to cover 3 topics, and all these 3 are important.
Yes, sir.
So,
I have reduced the slides, sir. As you said, 1 hour only. I have reduced my slides. It is 150 around. I have little bit reduced it to 100.
Yeah. So kind of you, and it was really very informative and very useful to the practitioners. You can throw little bit more light on results of Uttar Basti if you want to share.
Yes, sir, because I am very short of time, and sir has said me before 2 days. And in these 2 days I have prepared this, and all work I have already discussed with you. These are going on. So there are very few time which I have to prepare this all presentation. There are some success stories are there which we have treated in our hospital, which I have to emphasize on that. But due to the shortness
Yeah,
of
you
time,
can you take 2-3 minutes on your results on Uttar Basti, and you please narrate it.
okay,
Yeah.
okay,
Please,
sir. I will show you. Yeah,
yeah. Results of Uttar Basti.
yes, sir.
Yeah, please. Because that will be useful to the audience, no?
Exactly, sir.
Clinical
Exactly.
aspect has to be given more
Yes, sir.
emphasis than
Yes,
the
sir.
theoretical, because already 4 hour session has been gone for prostate.
Exactly, sir. Exactly.
Yeah.
No, sir. Nowadays, the prostate
Yeah.
and the stricture is the most important.
Yeah.
That is, urology is now going towards the Ayurveda, and there are excellent results which we have. So this is the material I am going to use for the Uttar Basti, that is the sterile drops, betadine solution, dispo syringe, xylocaine jelly, medicated oil or grit, honey and rock salt, which is my preparation for the Uttar Basti, and which is also mentioned in the Sanhita also. Before going for the Uttar Basti, I am going to do this is the case report which I am going to show. There are 2-3 cases. A 59-year male old patient from Baroda, Gujarat, which is having complaint of difficulty of micturition, increased frequency of micturition. There is an occasional burning micturition. As per the history provided by the patient, he was admitted at at Gujarat Kidney Hospital at Baroda for the BPH, and he is operated there in July 2019. Later on, patient discharged from the hospital, but again after 15 to 20 days, he suffered with the same difficulty of micturition, increased frequency, urgency, and burning micturition. Then they diagnosed him as a bladder neck stenosis, and they again operated the same patient on October 2019. But even after this procedure, the patient symptoms recur, and this patient is having no history of diabetes mellitus, no hypertension, no any other systemic illnesses are there. Then in the December, the patient get visited to our hospital. We have done his uroflowmetry, which shows a maximum flow of 13.6 ml per second. We done the retrograde urethrogram of his patient, which shows a urethral spasm or complete stricture. I will going to show you the X-rays of this RGU. Yeah, this is the report of this patient. You can see here the dye is not going to pass through the urethra, and there is a stricture, that is the posterior urethral stricture. You can see this report of Jayeshbhai Patel, 59-year male patient on 19/12/2019. You can see here there is a complete obstruction, and then after that we have done this. After 21 days we have taken the repeat X-ray, and you can see the dye is easily flowing. And this is the same patient, Jayeshbhai Patel, 59-year male, and dated on, you can see here the date is the 12/1/20. So within 21 days we have treated, we have removed the stricture of this patient. This patient is not able to pass the urine. There is a trickling of the urine. He will go 50 to 60 times for urination in a day. And we have done before and after study of this patient, and we done RGU, and you can see the report also is there. This is the printed report from Karl Severson Hospital, 19/12/19, 59 years male patient. You can see posterior urethra cannot be negotiated, as the contrast is not passing into the bladder, complete stricture or spasm, and after 21 days the same patient is having no significant abnormalities detected, and patient has a very good symptomatic relief. After 6 to 7 months, patient again came to meet me, and he said now it is okay, but he has to go for urination 10 to 12 times in a day. So I again given him a one set of Uttar Basti, and now 6 months is over, patient still is happy. So I think more improvisation, more assessment of the Uttar Basti should be, and we should have to, our idea should be on the proper medicine, proper patient care, and after Uttar Basti, what medication we prefer, that we have to emphasize more. So this is one case. There are different cases are there. I am giving Uttar Basti like this. We are taking the drug in the syringe. We are directly infiltrating. This is the patient where the complete stricture is there. The drug is not going to pass. It will regurgitate. So in patient, I will use feeding tube. I am not going to show you the long video. These are the other patient in our post-graduate department. The post-graduate student are also practicing Uttar Basti. So this is the testimony of the patient. This patient which we have treated is saying that he is admitted there, so he is not getting the treatment. He is saying all these things. Thank you, sir.
So predominantly, what do you use for the Uttar Basti?
Sir, see, it depends upon, because taila is very important, and then sharp. Because what is stricture? Stricture is nothing but a fibrosis or a scar tissue. If we have to break down this scar tissue, we should use a tool which can act there, which can absorb there, and which will start lekhan, shodhan, bhedan, ropan, and all these activities. And we have a sharp. So I am using Yavak sharp. Most of the people are using Apamarga Shart in Uttar Basti also. But Apamarga, as you all know, as the urethra, the mucosa is very sensitive. So if there may be some chances of burning, some cystitis or burning micturition problem patient may have developed. Sometimes patient may be having hematuria. So these things can be happen. But we have to learn more and more so that we can adopt Apamarga Shartel also. We can use, but in my practice I am using Dashmul Tel, and now I am started using Bala Ashwagandha Tel. Mostly in prostate I will use the Bala Ashwagandha Tel, and in my PhD topic I am using Dhanya Gokshur Ghruta.
Okay.
In BPH I am getting good results with the help of Dhanya Gokshur Ghruta, Shar Basti, that is Yavakshar I am using, and I am using Dhanyak, that is Coriandrum sativum, Gokshur, that is Tribulus terrestris, and I am using Ghruta, Go-Ghrut. I have prepared the drug and using it with the Yavaksha.
Very good, sir. It's excellent. Excellent to know all this.
Yes,
So
sir.
ultimately, I know that Uttar Basti is the things which acts on locally on all these diseases.
Exactly,
And
sir.
my topic was also Kshar on prostate, but
Okay.
at that time we were giving orally. But nowadays I am seeing that people are using
Sir,
Kshar
as
locally.
per as I am studying like that, I am also pursuing my PhD. So I would like to add one thing, that we should have some systemic effect also, sir. It is not like that only we are giving the shower and it acts on the local gland. It is not like that. There may be some systemic effect. Like that we can see in modern science, they are saying that there is a two theory are there. One is the hormonal theory, and that we should have to correct
Yes.
pharmacologically.
Yeah, that we have discussed at a length in my
Yes, sir.
my session, so
Exactly,
we will
sir.
not take it again.
Yes,
But yeah,
sir.
really, it was very informative and excellent session. Thank you very much, sir. We will take question answer at the end of the session. Will it be fine?
If you take now, sir, it is beneficial for me because they are waiting for me. As I discussed with you, I have some work there. That is my new home is going on, and they are working there, and I have to shift tomorrow there. So if anyone is having question, they can ask me within 2-3 minutes. Is it
Which
okay,
drug
sir?
you have for Snehan before radiation therapy?
Yeah, radiation therapy. Before, if you give us Snehana, that is called as a Panchatikta Ghrutapan, or you can go with the Dashmul Ghrut also. As you all know, radiation, what it will do? Radiation will get deneutralize the skin area, deneutralize the tissue area, the nutrient get dislodged, and you all know Panchatikta Ghrut and the Rasayan therapy is add-on effect will give a more strength to combat these problems. these side effects of the radiotherapy and chemotherapy. So they will overcome these all the side effects. So as an adjuvant therapy, we can give to the patient. We can start the patient with the initially we will give the 10 ml of Grutpan daily, and we will increase 10, 15 ml daily basis, 15 ml, 20 ml, up to 30 ml we can give as per the patient condition, as per the patient capacity.
Specific rasayan as per your experience useful in
Amal ki rasayan is very useful, as I have my own relative is there which is having bladder cancer, and I have suggested him Amal ki rasayan before going for the procedure, and he is getting very good result. He is in Aurangabad, and recently before 8 months he has diagnosed with the urinary bladder cancer. He has operated for the same, but after the chemotherapy and radiation therapy, he is not willing to go for the next session of the chemotherapy, and he called me what to do. I advise him, you have to take the chemotherapy and radiotherapy because there is no other option, but I will start with some medicine, you have to take this, and he is happy. There is some sort of relief he has taken, and he is happy now. So
yeah, somebody has asked your personal number to share. So if you wish to share, you please share on the chat box.
Okay, I will share my personal number.
Okay.
Yes, sir.
Yeah. So thank you very much, sir. There will be a very small memento from our end, which will reach to you in a few days. So please share your address on the to me, so that will be done.
Yes, sir. Thank you very much, sir. Thank you, Nilesh, sir. Thank you very much. Thank you.
Thank you, sir. Thank you very much, sir. So now we will move on to the another session, which will be taken by me. Friends, I am going to take one small session, because I have observed that there are so many students and young participants are there, and I think so that would be useful for them to start their practice. And there are some other important information regarding the insurance also, regarding the professional indemnity and all, which I am going to share with you. So please be with us, and uh, please listen to us. We want to convey certain messages also to all the participants in today's session. So I request all of you to remain with us till the end of the session. Uh, Friends, let me tell you that whether accreditation is required or not in your practice is really an important topic. Why am I saying that? We do practice, but we do not get our centers accredited. What is the difference between the accredited center and a non-accredited center? What are the advantages of accredited center? That let us understand. So the students and the young practitioners will have a benefit to have an advantage of accreditation over the non-accredited setup. Friends, you know, before COVID, the practice was flourishing. But after the COVID era, all the practice has gone down deeply. Similarly, it can happen. Uh, you see, basically, the need of the accreditation is from two point of view. One is that symbolizes that your center is having some important features what we need to have or what we need to practice in our ethical practice. And another is the reimbursement. I know that all these things you know very well, so I'm skipping these 3-4 slides. But this is regarding the hospital accreditation and uh, clinic accreditation. These are the two important aspects and two different things. You know, the when you want to go for the hospital setup, you need to have a different type of the setup, and you need to have specific guidelines for the erection of the nursing home, and all these guidelines were in the previous site. But that is not, I suppose, is much important. But whenever you have a hospital, you need first you need to get the Rohini registration, and then if you have a Rohini registration, then only your cashless claim can be reimbursed. You can obtain the cashless therapy at your setup also. Ayurvedic hospitals also can cater the cashless therapy, I mean treatment. Let it is very few centers, but particularly in surgical setup, yeah, because I am seeing that there are so many uh, doctors who are attending these sessions. They are basically a surgeons, uh, and for them they are practicing, but I suppose they probably might not be having the uh, accreditation. So for them also this is of little use, that why they need to have their Kshasutra setup registered as well as the accredited one. Because you know that in near future, uh, it is going to be mandatory to get the reimbursement. If the patient has taken the treatment from you, and if they want to get the reimbursement, in just actually speaking, it is on this 25th of November was the last date to get yourself registered as an accredited one, and then only your patients can be reimbursed. But because of the COVID era, this date would be definitely extended. So these and accreditation is of two types. If we talk about the nursing home, that is of entry level and full length level. Entry level accreditation has around 150 norms which we need to fulfill, and if we want to go for the full length, it is of say about more than 600, and is little difficult for a smaller nursing homes. But with all the efforts, we are going to have a OPD base and a 5-bedded hospital type of the uh, setups which can be covered under the Mediclaim. For an Ayush setup, it is mandatory to have an NABH certification before 25th November 2020, as I said. But yeah, date will. I'm sure that this date will be extended. So, what are now? One more thing has come up. What the norms? What I have told you is the 150 norms which are to be fulfilled. That is for a general nursing home. But as a pre-entry level NABH for Ayush setup is still further convenient, and to have those accreditation has been made more simpler. Uh, so even if you are planning to have a your own setup, a small hospital along with your Panchkarma or Kshatritra therapy, then these are the basic requirements one should have. An Ayush hospital is a healthcare facility wherein medical, surgical, parasurgical treatment procedure and intervention are carried out by Ayush medical practitioner comprising of any of the following: central or state government Ayush hospital, teaching hospital, Ayush hospital standalone or co-located with the other hospital, or at least five inpatients beds, having qualified Ayush medical practitioner in charge round the clock, having dedicated Ayush therapy section as required and or as equipped operation theater where surgical procedures are to be carried out, maintaining daily records. I mean, this is one of the very important part. Uh, so these are the basic requirement for the Ayush hospital. If you fulfill If you have these criteria along with the pre-entry level accreditation, I suppose will help your patient to get reimbursed the charges what he or she has paid. And I suppose in today's era, everybody would like, the 25 to 30% of the population is covered under the Mediclaim facility, and in urban area, majority of the people would like to get their claim reimbursed. So they prefer the treatment where they get the treatment as well as the financial support from their medical company, insurance companies. So it's better that let all of us, whosoever is having a hospital, let us create this criteria. These facilities at our setup. Or if we want to have a Ayush daycare center, then that means that it includes community health center, primary health center, dispensary, clinic, polyclinic, or any such health center which is registered with the local authorities wherever applicable, and having facilities for carrying out treatment procedures and medical or surgical parasurgical intervention, or both under the supervision of registered Ayush practitioner on a daycare basis without inpatient services, uh, but they have to follow certain criteria. What those criteria are, that it should have a qualified registered Ayush medical practitioner as an in charge, should have dedicated Ayush therapy section as required, and or has equipped operation theater where surgical procedures are to be carried out, and maintaining daily records, again a very important tool uh, one has to have. So if we have these two things, then Ayush hospital and Ayush daycare centers referred above shall also obtain either pre-entry level certificate issued by NABH. Means now once you have this Ayush hospital or Ayush daycare center, then it should get NABH accreditation. And if you get NABH accreditation, then only your patient will be reimbursed. All existing Ayush hospitals and Ayush daycare centers are complying with the requirements referred under clause above within a period of 12 months from the date of issue of this circular. Means this circular was given a year ago, and those hospitals which are new has to have accreditation right from the beginning, and those who are already existing should comply with this accreditation within next 12 months, and then your patient can have a reimbursement. So what are the advantages? Now you see that it creates certain no set protocol, and that helps you in preventing you in so many other medical legal issues also. Now then you will have a unique hospital ID number, or unique your center uh, ID number, your IPD number. Then you have a consent for anesthesia, surgery, recording of surgery, operative notes, anesthesia records, and indoor case paper, discharge summary, autoclave register, OT temperature register, refrigerator temperature register, blood transfusion registration, transfer register, death certificate, death register, estimated cost signatures, bills and reports, handover register, hospital cleansing register, feedback form. These are the important features which we need to follow once you get the accreditation. Now, what is the advantage? You see, this will indirectly help you help you in providing a quality treatment to your patient. That is one thing. Because 24/7 you are not there in the hospital. So once you have a feedback form and all these registers, what is going on in your absence, that also you come to know if all these protocols are followed. No? So if this has been followed, if some cases are sued against you, at that time, if you have all these records, you can definitely fight legally with documentation for those claims, because nowadays Consumer Protection Act is also a very important act, and it's, as all of you are aware, that it's very common that people choose the doctors very frequently. So as I said that, uh, what are the other advantages? One, as I said, it's medical legally, that makes you safe. As the setup is accredited, people will have develop the faith and can have references from across the globe. You can charge more, and you can provide the cashless services wherever you can. So these are the advantages. So one should have NABH accreditation to provide uh, and to gain or to uplift our practice. Why I have chosen this subject in this nephro-urology course? This is because that all the entire course what we have formed was focusing only and only on the clinical aspect. But at the same time, administrative aspect is also very important and one must know it. Uh, Now, when we talk about the advantages, we must talk about something which can be, uh, threatening to us also. As I said, that medical legal things. Whenever patients use you, it's use you in crores, in lakhs, and if we need to pay those money, it probably it could be your 5 years, 10 years, or entire life spans collection what you have done throughout the life. So what do we need to understand? So we did a survey, and it was really shocking that majority of our practitioners, they do not have professional indemnity. And if at all they have with their own way where there is no specifications. So to have an indemnity policy, but there is no specification, and what does it cover, and really what do we practice, whether it is covered or not, is equally important. So what we have observed that 99% of our practitioners probably today do not have professional indemnity. They do have mediclaim, but they do not have professional indemnity. You see, you may or may not have mediclaim policy, because normally whatever your mediclaim policy is of say about 5 lakhs, 10 lakhs, 15 lakhs, that's it. 0.001% people might be having a mediclaim policy of say about more than 50 lakhs rupees or so. When we pay the hefty amount for taking the mediclaim policy, say it costs you around, say about, if I want to have a 5 lakhs of rupees policy for my entire family, I might be paying say about 25-30,000 rupees. And if I want to take it for say about 15-20 lakhs of rupees, I might be paying for say about 50-60,000 rupees for the same mediclaim policy. But the policy which covers your professional indemnity with very meager amount, that we do not take. And what we need to pay to the a patient, probably sometimes in lakhs and lakhs of rupees and crores of rupees. So, friends, it's mandatory to have a professional indemnity policy with specific uh, terms and conditions. Uh, See, there are another issues that when you practice some specialty and you do not carry that particular qualification, gives you certain problems. So better always practice what you are entitled to practice, particularly when you want to do the specialty practice. Otherwise, nowadays the compensation is as very hefty. So one must have professional indemnity. Otherwise, we can have our graph like COVID era, what we were used to have. There are so many difficulties faced in day-to-day anorectal practice, which I am not probably going to take into detail over here because it's not uh, these these are not the few things which required. But one more thing uh, I would like to highlight is uh, cross-petty practice. Cross-petty practice is many a times is not covered under the professional indemnity. Uh, so, friends, it's my sincere request to all of you, as I have written on group also, that one must go for the professional indemnity. But what kind of the professional indemnity you should look for is, if you go for the individual professional indemnity, that policy does not have a defined terms and condition for Ayush practitioners. So many a times it has been observed in consumer court that the insurance company, in spite of having the professional indemnity policy, raise their hands and they say that yeah, this is not covered under our this policy. So, in spite of having the professional indemnity, if the patient has sued you and you need to pay some amount, the insurance company will not pay on behalf of you. So it is better to have a professional indemnity which are having a specific agreement, and it is not going to possible for an individual to have a specific and special agreement, because no insurance company is interested in doing a professional indemnity which gives you say about a business of 5,000 rupees or 3,000 rupees or so, and then they will do the entire process for you to get your conditions approved from their head office. No? So it is better to have such professional indemnity from organizations where the organizations are having the tie-up with the insurance company and which really uh, specifically speaks about the coverage. So this is one policy what we have at our association since 2002, which has been reinvented and redefined just a year ago. So the professional indemnity what AAP provides is that it covers both your Ayurvedic as well as allopathic practice as allowed by MCIM and agreement with the association. Let me tell you over here that when specifically we have taken it for our members over here, uh, the allopathic practice is covered as per the state council. So whichever the council covers your allopathic practice, this group professional indemnity policy will also cover your uh, insurance of the allopathic practice also. It also covers legal fees liability of civil claim as per the policy, out of court settlements, multiple claim settlement with insured limits available. And friends, believe me, the cost of a 40 lakhs of rupees coverage comes to you at the rate of 2.75 rupees per day, and probably it comes to, if I don't forget, it comes to in between 1200 to 1300, in the range of that, or something like 1500 maximum. So within 1500 rupees, because it's a, we have got a heavy discount from the insurance company. There is a 50% discount with this group mediclaim policy. So instead of having a 3000 rupees of premium, it comes to 1500 rupees also. If it is of say about your premium is, many of the people now, our group, I mean our members have taken a policy for say about more than a crore of rupees, and this 1 crore of rupees policy is just within 3200 and something rupees, which is, if a non-member takes this, then it comes to 6800 rupees or so, and still all these conditions what we have with the insurance company will not be there. So it is our sincere request that you go for such type of the policy. It also covers Ayurvedic Panchkarma treatment. Friends, nowadays after giving the Panchkarma treatment also there are problems and issues. And if such issues arises at that time, this policy also covers your that Panchkarma treatment too. These are the very specific conditions which we have. So, friends, it's our sincere request that you take this type of the policy, whether after becoming the member of this organization or wherever you are practicing, you form some organization and have a negotiation with your insurance company and can have such type of the policy for your coverage of your practice. Friends, it's my pleasure to tell you that this Devangi hospital, which belongs to me, where predominantly it's a surgical daycare center, and we do a proctology practice as piles, fissure, and all these surgeries we perform, and at the same time, many other general surgeries also we perform. And this is probably the first standalone Ayurvedic proctology hospital in the country which has been accredited as NABH. So, friends, you must need to change the mindset. Showing willingness to take pragmatic risks, success will follow. What Mr. Kalam sir has said. So, these all are the needs of our today's practice. So, one has to have the this type of the indemnity policy, and we need to change our mindset. When you can take medical policy, why can't we take the professional indemnity policy? It's very damn cheap. A crore of rupees policy comes to you at 3,000 rupees. 40 lakhs rupees, just 1200, 1500 rupees. Still, we do not take. It's something surprising. One must opt for it and should take it. So, friends, this was a little presentation from my end regarding the need of the NABH to increase your practice and the professional indemnity. Let you might be seeing a one patient a day or in a month, but if that one patient sues you, can carry away your lots of money. So, to take care of earning as well as protection from carrying away of the money, these are the two important aspects of the life, two important aspects of the practice I have addressed in short. Thank you. Thank you very much, all the participants. Thanks for patience listening. Uh, Now I will request our next speaker, Dr. Satish Udek from Dudh Papeshwar Company for 5 minutes, and then we will move on to our next further discussion on the organization and its advantages. Dr. Satish Udek, sir.
Yeah, namaste, sir. Thank
Namaste,
you very
welcome.
much. Yeah, thank you. Thank you very much, sir. So once again, Sri Dudh Papeshwar is a very proud to be associated with the Association of Ayurvedic Practitioners on this very novel concept of urology course. So I will be very brief, as sir has said that the 5 minutes being allotted to me. So we, Sri Dudh Papeshwar Limited, serving the Ayurveda in the Ayurveda industry since 1872. Today I'm going to share you about the product pertaining to the urology segment, that is called as the Sheela Pravanga Moktik Yukta. Sheela Pravanga Moktik Yukta is a product which is effective on Shukrava Srotas with action as the Dahashaman Stamban. It is also useful in Prameha, Shukrakshaya, Ujashaya, and Dhatushaitil, having its main ingredient as the Shodhita Shilajatu, Pravala Pishti, Vanga Bhasma, Moktika Pishti, Sorna Makshik Bhasma, Bhima Seni Karpura, Kokshura, Vanshalocan, Ela, and Gudichi Sattva. Frankly, the name Shila Pravanga is derived from the three main ingredients, that is Shodhita Shilajatu, Pra is Praval Pishti, Vanga is Vanga Bhasma. It's effective in Prameha, Mutradaha, Mutrakrucha, Asthila, Klebya, Dorbalya, burning sensation of hands and feet in cases of the prameha and general debility. The advised dosage are 1 to 2 tablets twice a day with anupan as a milk. It's available in 40 tablet and 100 tablet formulation. Here I am showing you the product quality profile. As we always take care for our each and every product to be having the same batch to batch consistency. Whether the batch is being produced after 6 months, 3 months, or whether it is 12 months, it should be having the same standard, should be performed well with its parameters. So here, the first one is the TLC plate, what we are being seeing. It's the TLC plate at the right hand side, which is showing us the various color-like bands at a specific interval. So if you can see at 0.4, we are seeing a light blue. It is showing that batch 1, batch 2, batch 3, batch 4 are having the same band at the same frequency. So it means that the extraction of the ingredients are being equal in all these batches. The lower graph is a peak graph, a 3D peak graph, which shows the HPTLC pattern. HPTLC is high performance here and there chromatography, whereas batch to batch similarization can be seen in this 3D peak. At the right hand side, we can see the batch to batch consistency, particularly about the iron content in all three batches which has gone through the testing. The same can be said for the calcium content. Now, the calcium and iron is being abundant in the Sheila Parangovic Maxi due to its product portfolio. We Sri Dudh Papeshwar are having our own standard, which is called as the Sri Dudh Papeshwar standard. You can visit our website www.sdlindia.com. In product segment for each and every product, there is the special icon for its product monograph. A step ahead with the Pradhana Dravya, that is the Gokshura. Gokshura has been used to reduce the uric acid level also in stone formation, peculiar in urinary tract infection, also having the action as the blood glucose lowering. It is anti-urolytic, also as the hepatoprotective. There is the common active alkaloid in Gokshur, which is called as the diosgenin, which has been seen to improve the diabetes complications in dyslipidemia and inflammatory disease. Here we are seeing the HPTLC graph analysis where this diosgenin is being seen to be comparing with the standard. Here we are comparing the standard what the Ayush Ministry and even Ayurvedic Pharmacopoeia of India is being stated to us. So this is what we have been found out about our own product, that is Sheila Prangovic Moptic. And apart from that, with its ingredient like Shodhita Shilajatu, which is having the iron, Moptica pisti, calcium, Praval pisti, again with calcium. We are running our in-process products with the AAS, that is atomic absorption mass spectrophotometry, which gives us the elemental assay. If we are going to see the iron, how much quantity of the iron is present, the same applies for the calcium or any other element. So Sheila Jatu used in diabetic, urinary and immunity, even cardiac disorders, whereas Moptic and Pravalapisti reduces the heat in the body, brings the coolness in the digestive system. As far as the Mopticapisti is being said, even the Bhav Prakash, the shloka has described its uses in the first line itself is the Punsi Klibe. So it's useful in Klebe also, Napunsangta also. And my last slide will be its product portfolio and the review. Frankly speaking, with the Sheila Jatu, there are abundant research articles being present. Sheila Jatu is listed as the best rejuvenator, Uttam Rasayan, an anti-aging compound, increase the physical strength, promote the immune health, also useful in treatment of kidney disorders, genitourinary disorders, and a very good digestive agents. So this was about a brief about the physicochemical analysis standardization parameter of the Sheila Parangovic Moptic. Again, we thank the Association of the Ayurvedic Practitioner, Dr. Tushi sir, Dr. Trivedi sir, for this wonderful association with us and cooperation with us. Thanks once again, and thank you for the patience. Thank you, sir.
Thank you very much, sir, for your nice and wonderful presentation and the advantages of the product. And thank you very much, Sri Dudh Papeshwar, for supporting this event as well as evergreen support to the organization. Uh, Now I will request our President, Dr. Rajendra Ranawat, to start with some information regarding this association. Dr. Rajendra Ranawat.
Yes. Am I audible?
Yeah,
Am I audible?
yeah.
Okay. Thank you, Dr. Nilesh Doshi, to give me an opportunity to discuss or say something or to give any information regarding this association, what we did in the past and what we are doing now. This is a very old organization, I should say, because we have already celebrated 25 years of our association as Silver Jubilee program in Taj Mahal Palace Hotel. Now, this new course, which with the efforts of Dr. Nilesh Doshi and Dr. Umesh Khanna and other faculties, everyone's name I may not be able to take, but these two people have taken this mass task on their own shoulders, and they did it, and they fulfill it totally with the complete knowledge of the nephrology subject with a certificate course in not in India, but it is a global integrated course. First part. Second part, we have really organized number of conferences in the past, and number of things are going to come ahead on this behalf of this association. I thank all the delegates and all participants, as well as the people, those who are supporting this conferences, these webinars now, rather than the conference now, I should say. The seminars have over now. This is webinars are going on, but all the companies, those who are participating, supporting, and giving their valuable time to us, as well as in all respect for as far as finance is concerned, as far as support is concerned, as far as their information is concerned, they are all supporting. Among them, one of the name is Dhut Papeshwar, the other one is Ayush Medica, the Emil company, some Himalayas and other companies are also there. They are supporting this type of courses as well as the webinars from their whole heart. And that is why we could run this type of webinars, we could run this type of past conferences, and we have given the immense knowledge of the Ayurvedic topics along with this Ayurvedic webinars. And definitely we are getting a good knowledge of it. However, being the president of this association and an Ayurvedic physician, I must say that each and every topic, whatever we have taken up till today, are much more informative, much more practicable, and much more helpful to the practitioners as well as those students, those who are coming for this Ayurveda. This association's main aim is to uplift the Ayurveda from the bottom to the top, and that is what we people, along with our founder president Dr. Nilesh Doshi, we people are doing it very hardly. And I will thank from my depth of heart to Dr. Nilesh Doshi, because he has taken up all these efforts to make this program successful. And because of your participation and because of your delegations and the faculties, those who have supported on behalf of, only with a phone call, Dr. Doshi tried only with the phone call, and they have accepted our request on behalf of this association. So I first thank to Dr. Nilesh Doshi and the rest of the committee members and the total ARP team, that we people are doing such a nice job. I will say that for the upliftment of Ayurveda and for to share the total knowledge of everyone's practice. Thank you very much, Dr. Nilesh Doshi. I have shared my views to the delegates and the participants. Anything else do you want to know from me?
Thought of. And considering this pandemic, it was on hold. But after this pandemic, we are going to start something very exclusive. For that, we appeal all of you to become the member of this organization. Let you may not be from Mumbai, but from across the country and across the globe, we request you to become the member. Why? That in in a short span, we are planning to have expansion to have a representative of the area and of the states and forming the committees for the states as well as the abroad. So all of you are requested to become the member of this organization. And so now I will request Dr. Dilip Trivedi to say a few words.
Thank you, Nilesh bhai. Our President Sahib has already narrated everything, and whatever the work is going on, it's been seen by all of us delegates and the participants. Everybody can understand what a mammoth task. It was a very big mammoth task, and it has been done with everybody's cooperation and heads of Dr. Doshi, Nilesh Doshi, who has done par excellent job to complete this course, and along with him, Dr. Umesh Khanna, who has cooperated very well, and he has brought a very good speakers from the different uh, cities, not only from Mumbai, though he's from Mumbai, but he has brought like uh, different speakers and who has shared their views, experiences, which was a great experience for us and which was a great time for us to learn so many things at this age. Let me tell, at this age, definitely. It's a learning process. Every day we are learning something. Every day we have to learn. Every day we have to update ourselves. And for that, association vision has been active for last 27 years. Now we have completed 27 years, definitely, and still more years to go ahead. And with everybody's cooperations and delegates and our members' cooperation, our committee members, those who are working very hard to make it, each and every program successful. And we are proud that each and every program has put some benchmark for every time. So I request the delegates, I request to become a member and to join with us, to boost up, to motivate us, to give and share more and more knowledge for Ayurveda. And we can come up with the more better programs, what we have done in the past. That is my request and appeal to everyone. Thank you very much.
Now I will request Dr. Deepak Rasal to say a few words. Dr. Deepak Rasal. By the time I will request Dr. Vinod Pandey. Dr. Vinod Pandey, please. Pallavi, Dr. Sujit Kaur is there. Yeah, madam. Dr. Sujit Kaur. By the time, please you start.
Yes, sir. Good afternoon or good evening, everybody. I feel that एक जो लकड़ी होती है, or maybe a small stick, it is easily broken. अगर आप उसी टाइप के स्टिक्स को अगर आप साथ में रख लो तो उसको हम तोड़ नहीं पाएंगे. तो वैसे ही मैं यहाँ पर कहना चाहती हूँ कि अगर हम साथ में मिलकर रहते हैं तो कोई और बाहर का इंसान आकर हमें तोड़ नहीं सकता. तो सबसे पहला काम जो ऑर्गेनाइजेशन का होता है, इट इज लाइक वी गेट सपोर्ट फ्रॉम ईच अदर एंड वी ग्रो टुगेदर विथ नॉलेज, विथ एक्सपीरियंस, एंड इट इज ऑलवेज अ तद्विद्य संभाषा. मतलब जो आयुर्वेद के बारे में जो भी हमारा नॉलेज है तो वो बढ़ता ही है. एंड विथ एसोसिएशन ऑफ आयुर्वेदिक प्रैक्टिशनर्स, the way Dr. Nilesh Doshi and our senior doctors, Dr. Dilip Trivedi, Dr. Rajendra Ranawat sir, so all these people, they take so much of efforts to impart higher knowledge and higher experience amongst all of us. And we all will grow definitely. So I think so. We should take benefit of this opportunity. Also, one I think so. Association of Ayurvedic Practitioners itself is a brand name now in the field of Ayurveda. We are known to give the best conferences and the best knowledge. At the same time, I think so. Nilesh sir has come up with a unique indemnity policy for the practitioners. So we should take benefit of it and let us be connected through Association of Ayurvedic Practitioners. I am happy to be here and I'm sure you all also will be happy. So we all welcome you wholeheartedly. Please join our organization ASAP. Thank you. Yes, sir, you can go ahead. Thank you.
Now I will request Dr. Deepak Rasal.
Hello.
Yeah.
Sir, I'm audible.
Yeah, but not visible.
Due to some
Yeah.
problem,
Yeah.
there are some problems. So,
Yeah. At least you start talking.
नमस्कार टू ऑल. इस एसोसिएशन से जुड़े हुए मुझे लास्ट 10 साल हुए. अभी मैं एज अ जॉइंट सेक्रेटरी के तौर से काम कर रहा हूँ. काफ़ी कुछ इन सालों में काफ़ी कुछ एक्सपीरियंस किया. बहुत सारा सीखने को मिला. एज अ मेंबर मैंने जब ज्वाइन किया तब काफ़ी मन में सवाल थे. लेकिन मतलब क्यों ज्वाइन हुआ, पहले तो ये सवाल था कि क्यों हम किसी एसोसिएशन से जुड़े. मैं मेरे एज अ प्रैक्टिस में खुश हूँ, क्यों किसी ऑर्गेनाइजेशन की हमें ज़रूर लगती है. ये सबसे बड़ा मेरे मन में सवाल था. लेकिन जब मैंने ये एसोसिएशन ज्वाइन किया और मुझे तब पता चला कि ये एसोसिएशन के माध्यम से कई सारे अपडेट्स हमें मिलते हैं जो हमें रोज़ की प्रैक्टिस में बहुत हेल्पफुल रहते हैं. दूसरी चीज़ हमें बाकी कलीग्स का एक सपोर्ट रहता है कि अगर हमारे रोज़ के प्रैक्टिस में कुछ प्रॉब्लम्स आए तो एसोसिएशन हमारे पीछे खड़ी रहती है. जो एसोसिएशन ने काफ़ी इन 25 साल में जो कॉन्फ्रेंसेस या हमारे हर महीने के पहले शुक्रवार को लेक्चर्स होते हैं जिसमें आयुर्वेद के ऊपर चर्चा होती है, साथ में साथ मॉडर्न विषयों को भी इंक्लूड किया जाता है. तो इससे निश्चित तौर पे नॉलेज तो अपडेट होता ही रहता है, साथ में कुछ नया सीखने को मिलता है. दूसरी सबसे इम्पोर्टेंट चीज़ है कि एक सेल्फ डेवलपिंग जो रहती है वो हमारा जो व्यक्तिमत्व विकास बोलते हैं या वो 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 ज़्यादा इम्पोर्टेंट रहता है. और वो मेरे हिसाब से मुझे उसकी बहुत सारी हेल्प हुई. मुझे काम करते हुए बहुत सारे जो गुरुवर्य है वो उनसे आयुर्वेद के क्षेत्र में या मॉडर्न क्षेत्र में जो नॉलेजेबल पर्सन्स है उनसे मुलाकात करने का मौका मिला. उनके थ्रू मुझे कुछ सीखने का मौका मिला. जो हमारे इंटरनेशनल कुछ कॉन्फ्रेंसेस हुए उसमें पार्टिसिपेट करने के बाद पता चला कि नहीं, एसोसिएशन से जुड़ना बहुत ज़रूरी है. जैसे हमने लास्ट 1 साल से ये जो इंडेमनिटी पॉलिसी शुरू की है, वो पॉलिसी की आवश्यकता कितनी ज़रूरी है, क्योंकि आए दिन हमारे सरकार के नियम बदलते रहते हैं और हर एक प्रैक्टिशनर को एक बैकअप होना बहुत ज़रूरी है. इसलिए हमारे एसोसिएशन जितने भी प्रैक्टिशनर्स है उनके हित के लिए चर्चा करती है. आयुर्वेद का प्रचार और प्रसार कैसे हो इसके बारे में विचार किया जाता है और यही सभी बातें ध्यान में रखते हुए डॉक्टर नीलेश जोशी सर, डॉक्टर रानावत सर, डॉक्टर त्रिलीप त्रिवेदी सर, हमारे डॉक्टर संजय वानी सर और हमारी पूरी ऐप की टीम कि हम नया कुछ लेके आ सकते हैं जिससे प्रैक्टिशनर्स को ज़्यादा से ज़्यादा फ़ायदा हो, ज़्यादा से ज़्यादा नॉलेज गेन हो सके. इस तौर पे हमारी चर्चा होती है और मैं आशा करता हूँ कि इस कोर्स के माध्यम से जुड़े हुए सभी डेलीगेट्स को मैं यही आह्वान करूँगा, यही अपील करूँगा कि हमारे एसोसिएशन के साथ बने रहे निश्चित ही तौर पे हम और नया नया कुछ लाने की कोशिश करेंगे, जिससे आपके प्रैक्टिस में एवं आपके आपका कोई भी निजी दौर पे प्रैक्टिस के रूप में कोई परेशानी होती है तो बिना हिचक हमारे टीम में से खासकर नीलेश जोशी सर हमारे पीछे इज द वन ऑफ द बैकबोन ऑफ अस, सो वो हर समय हमारी मदद करते हैं। तो मैं आप सभी को अपील करूंगा कि जल्द से जल्द हमारे एसोसिएशन का सदस्य बने। थैंक यू। थैंक्स।
Dr. Sweta Ben, please say a few words.
Am I audible?
Yeah,
Yes.
but not visible.
Okay, okay.
हाँ
Now,
Yeah.
हाँ, ये beautiful
Very-
lady is there. We can see her.
थैंक यू सर। आप सभी का मैं आज हार्दिक स्वागत करती हूँ। नाम तो बहुत बार देखा होगा शायद ग्रुप में, आज सब पहली बार मुझे देख रहे हैं। मैं ये एसोसिएशन के लिए कुछ कहना चाहूंगी। मैं शादी करके आई मुंबई में, पिछले 10 साल से यहाँ आई, तो एक आयुर्वेद डॉक्टर होने की वजह से यहाँ मुझे कैसे काम करना चाहिए, कैसे शुरुआत करनी चाहिए, गुजरात से यहाँ एक स्टेट पूरा बदल गया। तो उसी टाइम सबसे पहले मैं नीलेश सर से मिली थी, तो एट दैट टाइम ही गाइडेड मी कि आप ये सर्टिफिकेट लीजिए और ये शुरुआत कीजिए। दूसरी बात बोलूंगी कि जब से ये एसोसिएशन ज्वाइन किया है तब से मुझे मेरे सीनियर्स का, मेरे फ्रेंड्स का पूरा सपोर्ट मिलता रहा है। अगर हम प्रैक्टिस करते हैं तो कहीं हम अटकते हैं, एट दैट टाइम वी नीड, वो कहते हैं ना, लाइफ लाइन चाहिए होती है। तो मेरे जो सीनियर्स हैं, नीलेश सर, रानावत सर, त्रिवेदी सर, वो मेरे लाइफ लाइन जैसे हैं। तो जहाँ पे अटकते हैं दे गाइड अस, सभी जगह पे मदद करते हैं। और जैसे आयुर्वेद में कहा है, हमें अगर कुछ नहीं मिलता तो इसकी वजह से मुझे फ्रेंड्स भी बहुत मिले हैं। और ये एएपी है, वो मेरा एक परिवार है। जब अपने ही फील्ड के लोग अपने परिवार की तरह लगे तो काम करने का मजा ही कुछ और होता है। और हर दिन इसमें से नॉलेज ही हम प्राप्त करते हैं, नई नई चीजें करते रहते हैं। वी वर्क टुगेदर, वी आर एएपी। थैंक्स टू ऑल। एंड हमारे सदस्य बनिए और हमसे जुड़े तो हमारा कैसे परिवार बढ़ता जाएगा, वो वंशवेला जैसे बढ़ता है तो ये उसकी हमारी डालियां में से पेड़ बढ़ता जाएगा। तो वी वेलकम यू ऑल, जॉइन अस। थैंक यू।
Now I will request our secretary, Dr. Vinay Jha sir. Dr. Vinay Bhai, who is also one of the backbone of the association. Yeah. Boliye,
Thank
sir.
you. I'm visible.
Yes, yes.
You are
Thank
audible
you.
and visible both.
थैंक यू। मेरे पहले हमारे प्रेजेंट प्रेसिडेंट, पास्ट प्रेसिडेंट, ज्वाइंट सेक्रेटरी, एक्टिव मेंबर, फाउंडर प्रेसिडेंट, सबों ने हमारे एसोसिएशन के बारे में काफी कुछ कहा। मैं आप लोग से एक रिक्वेस्ट ये करना चाहता हूँ कि किसी भी एसोसिएशन को की पहचान होती है कि उसके मेंबर कितने हैं, दूसरी पहचान होती है कि उसकी एक्टिव मेंबर कितने हैं, तीसरी पहचान होती है कि वो वर्क क्या क्या करता है। तो हम वर्क तो बहुत अच्छा कर रहे हैं, हमारे पास एक्टिव मेंबर भी है, लेकिन फिर भी कमी पड़ती है कि हमें और एक्टिव मेंबर चाहिए, हमें और मेंबर चाहिए। मालूम नहीं क्यों, समझ में नहीं आता कि हम बीएमएस के इतने डॉक्टर होके भी क्यों नहीं जल्दी मेंबर बनना चाहते किसी अच्छे। एपी एसवन से ज्यादा एक फैमिली है। आपको कोई भी प्रॉब्लम होगा, आयुर्वेदिक साइड, मॉडर्न साइड, किसी भी डॉक्टर से हॉस्पिटल में कोई भी प्रॉब्लम होगा, आप एक मैसेज देंगे हमारे एसवन के इस पे, एपी पे, तो तुरंत आपको उस चीज के बारे में कंक्लूजन मिल जाएगा, रिजल्ट मिल जाएगा, ये चीज ऐसा 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 होगा। कभी भी कुछ भी मेडिको लीगल केस होता है, कोई भी तरह का प्रॉब्लम होता है, आप एक मैसेज भेजते हैं हमारे व्हाट्सएप ग्रुप पे, तुरंत आपको कई लोगों के मैसेजेज और जानकारी आ जाती है, भाई आपको इस तरह से ये चीज करना है, हम ये चीज करने जा रहे हैं। तो मैं ये बोलूंगा कि हमारा सन एक के बाद एक कई बड़े बड़े काम कर रहे हैं और आगे भी करेंगे। आप लोग ज्यादा से ज्यादा लोग इसके मेंबर बने, इंडिमनिटी बॉन्ड वगैरह जो भी सन वर्क करते हैं उसमें सब लोग खुले दिल से सहयोग करें और ज्यादा से ज्यादा मेंबर बने। क्योंकि कोई भी डॉक्टर भी आते हैं तो वो देखता है कि नंबर ऑफ कितने लोग लिसनर है। आज उस दिन बोल दिए उमेश खन्ना कि 186 पहले दिन थे, अभी इतने ही आते हैं। तो क्या हम लोग क्या एक्सक्यूज देते कर काम रहता है, ये रहता है, लेकिन अरे 2 घंटा तो निकालो हफ्ते में, एलोपैथी के लिए, आयुर्वेदिक के लिए 4 घंटा नहीं निकाल सकते हम लोग, इतने थोड़े बिजी है। बहुत से लोग निकाल रहे हैं, जो निकाल रहे हैं वो बैठ रहे हैं वो टाइम, तो उनको भी तो एक वो मिलता है कि इतने सारे डॉक्टर लोग हमारा सुनने को आते हैं। वो लोग अपना एक्सपीरियंस लाइव का, वो जो पढ़े हैं उसके अलावा वो जो लाइव में जितना चीज देखे सीखे वो सब आपको बता रहे फ्री में, फिर भी हम उसको देखने सुनने को नहीं आते। हमें क्या चाहिए, खाली पीडीएफ फाइल में ये दे दो वो दे दो। अरे सुनने की भी हमें कोशिश करनी चाहिए। सो प्लीज मैं यही बोलूंगा, ज्यादा से ज्यादा सब लोग मेंबर बन जाए एएपी के, और कुछ भी प्रॉब्लम हो तो हमें उसके लिए पूछे, हम लोग हेल्प करेंगे।
थैंक यू विनय भाई, आपने बहुत अच्छी तरह से, आप पहले से एसोसिएशन से जुड़े हुए हैं तो काफी चीज आप बता पाए और लोगों को अवगत कराया। मैं सब जो डेलीगेट्स है उसमें से भी अगर किसी को कुछ बोलना है तो मैं उनको रिक्वेस्ट करता हूं कि वो चैट बॉक्स में डालें, तो हम उनको अपग्रेड करेंगे और उनको बोलने के लिए मौका देंगे। उनको क्या तकलीफें हैं, जुड़ना चाहिए कि नहीं जुड़ना चाहिए, क्यों जुड़ना चाहिए, ऐसा कोई भी सवाल है तो पक्का आप आपका हाथ रेज करिए। पल्लवी, जो भी ऐसा रेज करते हैं उनको अपग्रेड करो। हाँ,
ओके सर।
या
There are 3 raise
या
hands.
या so now I will request Dr. Nitin Goradia to say a few words. डॉक्टर नितिन गोरडिया, तब तक मैं रिक्वेस्ट करूंगा डॉक्टर शशिकांत लांडगे को। डॉक्टर शशिकांत लांडगे, पल्लवी, please upgrade Pallavi, Dr. Pallavi. I request Pallavi to upgrade Dr. Pallavi Sodhi Patankar. Dr. Sasikant, yeah, Dr. Sasikant Landge would like to say something. Dr. Kalpana Chaudhary. डॉक्टर कल्पना चौधरी,
पल्लवी को किया है।
हाँ, तो तब तक डॉक्टर पल्लवी को बोलने दो फिर। हाँ, डॉक्टर कल्पना चौधरी बोलिए।
हेलो,
या बोलिए।
एज सच तो सब लोगों ने बहुत कुछ बोल दिया ही है, तो मुझे 1-2 वाक्य याद आ रहे हैं जो मैं यहाँ पे मेंशन करने जा रही हूँ। जैसे कि हमेशा कहा जाता है कि तद्विद्य संभाषा ज्ञानवर्धनानां श्रेष्ठः। यही एक टारगेट लेके हमारी एसोसिएशन पिछले कई सालों से काम कर रही है। एंड जो मैंने इसकी विशेषताएं नोटिस की है वो ये है कि कभी भी इसका टारगेट एक छूने के बाद दूसरे ऊंचे टारगेट की ओर जाता है, और हमेशा ये रहता है कि कितना मेहनत लगेगी, कितनी परेशानियां आएंगी, उसके बावजूद करते हैं सिर्फ एक ब्रीद वाक्य लेके कि लो एम इज अ क्राइम नॉट द फेल्यूर, लो एम इज अ क्राइम नॉट द फेल्यूर। ये सोच के हर बार स्ट्रगल करते हुए, और हम लोग उस ऊंचाई को ही लेते हैं। हमारे पास लेटेस्ट एग्जाम्पल था ताज वाला। तो मैंने क्या कहना है, हाथ कंगन को आरसी क्या, पढ़े लिखे को फारसी क्या। जो हमारी एसोसिएशन काम कर रही है वो दिख ही रहा है, और वो अपने आप में एक स्वयं प्रकाशित सूरज है। मैं जानती हूँ कि आज मैं कहूँ या न कहूँ, जैसे जैसे इसका प्रकाश फैलता जाएगा, छोटे छोटे सितारे उसके सामने उसमें शामिल होते जाएंगे। ये एसोसिएशन बड़ी हो रही है, हो गई है, मतलब इसे आप सपोर्ट कीजिए, इसमें शामिल होजिए, ये बोलने की जरूरत ही नहीं है। अब लोग खुद होके पूछते हैं कि आपकी एसोसिएशन में कैसे शामिल हो जाएं। आई एम हैप्पी विद दैट, आई एम हैप्पी विद ऑल द एक्टिविटीज गोइंग ऑन, एंड व्हाटएवर जितना भी हम लोग काम कर रहे हैं, जो भी साइंटिफिक अप्रोचेस है, जो भी कल्चरल अप्रोचेस है, मैंने जैसे कहा कि इसका लिख करके नहीं, इट इज स्वयं प्रकाशित। And I'm thankful for giving me the opportunity, and I'm thankful to all of you to listen to me. Thank you so much. Thank you.
Kalpana Ben, you are my elder sister, so डॉक्टर पल्लवी मैडम,
इतना इंटेलिजेंट, इतना छोटा भाई मिलेगा इतना अच्छा, तो मेरे लिए तो बहुत अच्छा होगा।
मैडम।
Yeah, Dr. Pallavi, madam. Dr. Pallavi Patankar.
Yeah. Am I audible?
Yeah, madam, please.
Yeah. So a very good evening and pranam to all. It's wonderful to listen to all the stalwarts, their comments. I would just like to share with all the members that even I'm a member of AAP. I was in 2001 when I was the secretary of Obesity Society of India, and Sanjay Wani was the secretary of AAP. So I requested him to become a member of my organization. And he said, he's my batchmate. Sanjay Wani is my batchmate. So he said, I'm known as Pami Sodi. He said, Pami, why don't you become a member of my organization and I become yours? So this is how we exchanged our membership. I just want to express that these organizations, associations are such a wonderful platform to share your knowledge, to listen to experts, to share, to have a networking and ready answers available. You have a query in your practice, you can immediately ask the expert. So it's very knowledgeable and very beneficial for us clinicians. And I would really appreciate Dr. Nilesh Doshi, Dilip sir, Ranawat sir, and all the executive members, because even if they are post holders, I feel that they have to work. We are just workers in the executive committee. I have been the president of an organization and I have worked on all levels, right from secretary, treasurer, president, vice president. So there is a lot of effort involved, and I would request the delegates that it is your valuable time which you spare for the organization brings out these efforts, and they have all come up with flying colors. My best wishes, and I would request Dr. Nilesh Doshi sir and everybody to have a similar program on obesity, because with obesity a lot of comorbidities are associated, similar, and Ayush is still trying to set a role model for integration, but Dr. Nilesh Doshi has already set an example. So best wishes to all, and thank you for giving me the time. Thank you so much.
Thank you very much, madam. You are senior to me, and it's my pleasure and the association's pleasure to have uh, with us over here. Sanjay Bhai was supposed to be over here, but due to certain unavoidable circumstances, he is not there with us. It would have been our pleasure that today he was with us, then would be very much pleasant thing for us. Now I will request Dr. Nitin Goradia, who has again joined.
Good evening, everyone. I have been actively associated with the association since past 6-7 years. And after joining the association and attending its first biannual conference, I felt that the association is doing wonderful task, getting very senior and learned speakers all around India on a platform, and where you can definitely gain the knowledge. And I started since then working actively for the association, getting memberships, making people enroll in for the conferences, and this global integrated Euro nephrology course has set its standard, and it is really wonderful task done by Nilesh sir, Umesh Khanna sir, and the team. And as Madam Sodi said, we are looking forward such new courses ahead, and all the people will get benefited out of this. So all the best. Thank you. Thank you, Aap.
Thank you, Nitin Bhai, for your kind words. Now I will request Dr. Gladys Jadhav. Dr. Gladys Jadhav, please. By that time, I will request Dr. Chanda Biradar. Dr. Chanda Biradar, would you like to say something? Dr. Chirag Joshi? Yeah.
Yes, sir. Am I audible, sir?
Yeah, but not visible, sir.
Sir,
Yeah.
am I visible right now,
Yeah.
sir?
Yeah, sir.
Yes, sir. Sir,
Thank
good
you so
evening
much.
to everyone all. I am a member of AAP since 2 years, and I am very proud to say that my father was already old member of our AAP team, and I used to from my childhood days I used to join the seminars with my father, and I am very glad that this is a very great platform to learn from the great personalities in our field, that in any manner they are ready to teach, they are ready to solve our doubts. And I really appreciate for the AP team, Nilesh sir, Dilip sir, and Rajendra Rana sir, and looking forward for the new courses and new teaching for us to become nice physicians and lead a proper and healthy clinician life. Thank you, sir. Thank you so much, sir. AAP team. Thank you, sir.
Thank you, Chirag bhai. Dr. Vinayak Desai. Dr. Vinayak Desai, please.
हेलो,
Yeah.
एम आई ऑडिबल?
Yeah.
अच्छा, एएपी का पहले से कंसेप्ट यही है, एजुकेशन एजुकेशन एंड एजुकेशन, और एकेडमिकली इन्होंने अब ये एसोसिएशन ने बहुत कुछ किया है। हर 2 साल में जो कॉन्फ्रेंस होती है बड़ी बड़ी, और साथ साथ कुछ कोर्सेज भी होती है, वो कोर्सेज की वजह से आज हम लोग हमारे प्रैक्टिस में बहुत कुछ कर रहे हैं। जो कॉन्फिडेंस नहीं था कल तक, वो आज हम लोग ये कर रहे हैं। इसके आगे भी होते रहेंगे, ये मुझे विश्वास है, क्योंकि दोषी सर उसके लिए अथक प्रयास हमेशा ही करते आए हुए। तो एकेडमिकली मैं सबको मैं अनुरोध करूंगा कि प्लीज यहाँ ज्वाइन हो जाइए। साथ साथ कोई भी गाइडेंस चाहिए तो सर और सभी मेंबर्स यहाँ तत्पर हैं देने के लिए। और मुझे एक चीज मैं बोलूंगा कि थोड़ा यहाँ वहाँ कुछ काम किया तो सर ने मुझे बोला था, दोषी सर ने, कि आपको चेयरपर्सन बनना है। फर्स्ट टाइम मैंने स्टेज पे एंट्री की है, और वो भी दोषी सर की वजह से। तो ये अपना पर्सनालिटी डेवलपमेंट भी इसके थ्रू ही हो रहा है एकेडमिक के साथ साथ। तो मैं सबसे अनुरोध करूंगा कि प्लीज ये एसोसिएशन ज्वाइन करिए, और अपना एकेडमिकली नॉलेज वाइज अपनी भरभराट के लिए ज्वाइन करना बहुत ही जरूरी है। थैंक यू।
Thank you, Vinayak bhai, for your excellent comments. Now I will request Dr. Chandarani, are you ready to speak? Or I will request to upgrade Dr. Devansi Jaju. Pallavi madam, please upgrade.
Okay.
Yeah. And if anybody else want to speak, please raise your hand. Yeah. Because I am seeing that she is there. In spite of she has worked till 4 a.m. tomorrow morning to give you the notes, and then at 6 o'clock again she woke up and went for her new assignment. That's a great dedication and devotion what she is having to provide you the notes. I will request Dr. Devansi to say a few words. Yeah, unmute. Yeah.
Am I audible, sir?
Yeah.
So I would firstly like to congratulate AAP for successfully doing all the events. It was really pleasure. It was really my pleasure to be a part of this whole event, as I have learned a lot of things from it, and I'm so glad, sir, that even you are the whole team is so supportive. As you have as you have said few words about me, it is immense pleasure for me to hear such words from from whole team, from whole our team, and especially from you, sir. Though I have worked hard on all of us, all three doctors of us have done work, but the appreciation I got and the appreciation all three of us got from whole association was immensible and was so joyful. So I was so happy to work with with the whole association, and I will also look forward to be a member of ARP. And of course, I joined this, and with your wishes, I hope that I will also do my best here too. So I would, in my future also, I would like to be like you, be my mentor, and all the doctors be such supportive as they are in the time they are being here. So lastly, I am so thankful to ARP, and I am so grateful that I have attended this event. I was not known about this event, and I was not sure, but now I'm 100% sure that if any event comes in future with this association, I will be the first member to join them, because I'm so happy to join this in, as a fresher, as a new doctor in the Ayurved field. When I see doctors like you who are promoting Ayurved to a level, to an extent which people only think of doing, then I feel such a joy to see that people like you are doing such great work in Ayurveda, and they are making all the medical staff their family along with the allopathy. They just don't only do things, they believe in growing and make other people grow too. So it would be my immense pleasure to grow with you all and to be a member of ARP in my future, and I will definitely try to be a member of ARP association with my whole knowledge and with my whole heart. I congratulate and I thank our team and association for giving me this opportunity to speak in front of all the delegates and all learned persons, as I am just a student in front of you, sir. Just a mere student. Thank you so much, sir.
But you are so dedicated and so devoted that you deserve all three of you deserves the big round of applause.
Thank you
very
sir.
much. So with these, I will request Dr. Chandrasekhar Samant to conclude the session with vote of thanks. He is also one of the pioneer member of the organization, and is the hold many posts. Probably the cash treasurer. No, very important post. So I will request Dr. Chandrasekhar Samant.
Am I audible, sir?
Yeah, very well.
Yeah, very good evening, everyone. I am Dr. Chandrasekhar Samant. First of all, I must say I feel very proud to be a very, very early member of this association, and I have hold many posts also in this association, and this association has made me very, very मेरा पर्सनालिटी, मेरी नॉलेज, मेरी सब ओवरऑल ग्रोथ के लिए ये एसोसिएशन ने जो काम किया है वो बहुत ही बढ़िया है. फर्स्ट एंड फॉरमोस्ट I must come to today's sessions. I must thank today's speaker. Thank you, Dr. Shailesh Jaiswal, for enlightening us on the prostatic and malignant abscesses and urinary incontinences. Then I must thank Dr. Nilesh Doshi, today's star speaker, for a very useful lecture on NABH accreditation, Mediclaim, medico-legal aspects, and very important professional indemnity policy. I thank Dr. Satish and Dudh Papeshwar Pharmacy. Again, I must thank Dr. Nilesh Doshi, our course designer, Dr. Rajendra Ranawat sir, our president, Dr. Dilip Trivedi sir, and AAP team for making and designing of this uronephrology course. I also thank all the organizers, and last not but the least, our Association of Ayurvedic Practitioners for making this course possible and very success. I thank all the participating delegates on behalf of AAP. I thank all the members who have said so much very good remarks on our association. And please do join our association as early as possible. Thank you. Thank you all.
Thank you very much, Chandrasekhar Bhai, for giving a vote of thanks on behalf of the organization. Thank you. Thank you all.
Thank you.
Yeah, one more thing I would like to say, that on this Friday there will be two speakers, and next Tuesday there will be 3 speakers, because Dr. Manoranjan Sahu sir, who was supposed to take the session today, has not been able to join today. Will be also taking the session next time. So probably next time we will be starting it by 2:30 instead of 3 o'clock next Tuesday. Of course, this Friday would be at 3 o'clock, but on next Tuesday, probably we will start at 2:30. It would be little bigger session, because it would be the last session, and on that day we need to conclude the entire course. And then straight away we will move to the examination part. That would be after Diwali. And friends, it would be a MCQ type of the examination. We will send you the Google form, and you need to fill it up. And that's how it is going to be, the simple, straightforward examination. We will see to it that it would be easy also, and it would be little tough also. So thank you. Thank you all.